Tibia is a bone which is actually present right below the ankle, and it connects knee with the ankle joint actually. But it is very much, there is a subcutaneous border of the tibia which is on which there is very thin layer of the skin only visible. On the posterior aspect and on the posterior lateral aspect is actually surrounded by a thick muscles, especially the posterior compartment is quite thick as compared to the anterior compartment. When we are dealing with the tibial fractures, the most common mechanism is actually anterior blow to the tibia or the knee, because there is only thin skin over the top. Therefore, there is always an increased chance with high energy trauma can lead to tibial fractures. Now, tibial fractures may include tibial plateau fractures, such as involving the medial and lateral tibial condyles, along with the maybe associated knee injuries as well. They may involve the tibial shaft and the fibular shaft fractures, which may involve the middle one third or the distal one third of the tibial shaft. It could be an isolated tibial shaft fracture, which is more common in the case of the children, or it could be the tibial stress fracture, which is more common in case of athletes or army recruits, because they have, and when especially the athletes who are undergoing extensive training programs for their fitness. Now coming to the tibial plateau fractures. Tibial plateau fractures involve the medial and the lateral tibial condyle. Most commonly it actually occurs on the lateral condyle. Therefore, when we are classifying them, we start classification from the lateral condyle. Most commonly it is the result of high energy trauma, with especially when there is anterior force which is acting on the knee. For example, a pedestrian was crossing the road but was hit by the car. This is a classical type of injury which actually occurs into anterior knee injury and tibial plateau fractures. As you can see, this is a knee joint with the femur on the top. There is patellar bone which is actually forming a knee joint along with the tibia, with this lateral as well as the medial collateral ligaments. Usually with associated fracture, the most commonly it is always on the lateral side, leading to split fracture of the lateral tibial condyle. There is a Schatzker classification, which is actually present usually for the proximal tibial fractures. As I told you, the mechanism of injury is classically high energy trauma with front-on impact. Why? Because at this area, usually in the anterior one third and the middle one third, on the anterior aspect, the actually bone is quite very much exposed, because there is only a small part which is very much subcutaneous. There's only thick skin on the top. It's not actually protected by a lot of bulk of muscles. So whenever there's an anterior impact, this usually the most energy is absorbed by the bone, leading to this kind of a fractures. Classically, it is termed as bumper fracture, especially when a pedestrian is crossing the road and car hits the pedestrian. Or it could be due to fall with the main impact is actually the impact is on the anterior aspect of the knee, leading to crush tibial condyles as well. As I told you, there is a Schatzker classification and there is a Hall and Moore classification. But Schatzker classification is more used and is more commonly used in practice, especially when we are dealing with the treatment of the proximal tibial one third or tibial plateau fractures. There is a type 1. It has total 6 types. Type 1, it starts from the lateral tibial condyle. This is actually a split fracture of the lateral tibial condyle, making it a type 1. Type 2 is actually split with depression. There is a central depression along with the split of the one third of lateral tibial condyle. Type 3 is a kind of an injury in which there is only depression. There is no fracture of the lateral tibial condyle, but there is a central depression only. Then it's the type 4. Type 4 in which if the energy mechanism is such that the impact was from the medial side rather from the lateral side, then this may result in a fracture of the medial tibial condyle. In type 5 and type 6 is usually associated with a high energy trauma, and this may lead to either both the condyle fractures. Involving type 5 is the medial as well as the lateral tibial condyle shear off fracture. In type 6, the energy is so high that this fracture not only fractures the medial and the lateral, but it also has a metaphyseal extension, leading to type 6 fracture. Coming to the clinical features, as mostly the knee is involved, The most common feature is always the bruising over the anterior aspect of the knee, because the trauma is morely on the anterior aspect. The medial or lateral instability, depending upon whether, most commonly it is always associated with lateral instability because of the damage is more towards the lateral side. But this may, if in type 4 injury in which the medial condyle is involved, there may be associated medial collateral ligament injury leading to medial instability. Most commonly, whenever there is a fracture, there is intra-articular hematoma leading to bruising as well as swelling of the knee joint with excessive pain and limited range of motion, and usually may be associated with a nerve injury or neurovascular compromise as well. Now coming to some of the imaging, if you get a patient which has a history of head-on impact with the car or the bumper of the car with probably swelling, bruising as well as decreased range of motion and patient in excessive pain, the first and foremost is always the x-rays. You get an AP and the lateral view after the clinical examination. This is showing an AP view of a Schatzker type 1. You can appreciate the lateral split of the lateral tibial condyle. Then it's type 2, which is called as central depression plus the split of the lateral condyle. Then it's type 3, which involves mainly the depression, central depression of the Schatzker type 3. Type 4 is involving the medial condyle only. And type 5 is involving the both condyle, is called the bicondylar fractures, in which the lateral as well as the medial condyle both are involved. And in type 6, as I told you, is associated with very high energy trauma. This may be there may be both condyles may be fractured, as well as actually the fracture line extends into the metaphysis. If you appreciate it over here, there is a fracture of the lateral condyle, the fracture of the medial condyle, a whole chunk has been removed, and there are actually fracture lines crossing way into the metaphysis and almost reaching at the metaphysis diaphyseal junction. If you see, this is the lateral view. Similarly, you can appreciate that the fracture lines are actually making it reaching the metaphyseal diaphyseal junction and making it very much an unstable sort of a fracture. So if it's unstable, you need to treat it as well. Now, depending on why this classification is actually there, because it helps us to guide the treatment. As you know, by Schatzker type 1, there is definitely split, but it's not that much displaced. Type 2, in which there is displacement along with the depression. And then in type 3, it's depression as well. So there are different complications associated with different type of fractures, and you need to treat them accordingly. For example, in this case, you can appreciate that they have passed the screws to treat the to restore the article congruity. Then they have passed a proximal tibial locking plate, which is actually the long locking plate has been passed because metaphyseal diaphyseal junction has to be stabilized as well. Now, if it's type 1 undisplaced fracture, which was actually the split of the lateral condyle, but the split is there, but it's not displaced. The treatment is hinged cast brace and range of motion braced most of the time, or even we can apply a simple cylindrical cast as well. But this is usually bracing is more important, because with this you may not be able to put weight bearing straight away, but after 3 to 4 weeks, yes, some degree of weight bearing can be started. But what's important is in this brace, as you are making sure the knee is actually kept immobilized, so you do not start weight bearing straight away in this case. So if it's displaced fracture, displacement would mean that there is a category of displacement. Displacement is considered significant if there is more than 5 mm of displacement. Type 1 would mean that there is a actually split of the lateral condyle, tibial condyle with more than 5 mm of displacement. For that, you need to have an open reduction internal fixation or closed reduction with percutaneous fixation with screws. Both options are good enough. But if it is more than 5 mm displacement, usually you have to go for open reduction internal fixation with either use of screws or use of buttress plates, as you can be appreciated in this X-ray. So if it's type 2 was split, there is a central depression and there is a split as well. Now depression is also taken, there is a upper limit for that. Usually for any joint line, If there is more than 2 mm of depression, that is significant. In case of knee, the upper limit is 5 mm. So if it is more than 5 mm of depression, this will eventually have a lot of complications, for example osteoarthritis of the knee, so that needs to be dealt accordingly. There could be two types of patient. One could be really older osteoporotic patients. If there is slight depression or depression is less than 5 mm, you can go for a non-operative treatment. That is, this simply range of motion braces can be used, extension or knee immobilizers can be utilized, and later on, once 3 to 4 weeks have passed, where fracture starts to unite, we can restart with this partial weight bearing, eventually leading with aggressive physiotherapy. Regaining the mobility is relatively easy. You may not need to anatomically construct the knee joint. But if they are young patients and there is more than 5 mm of displacement or more than 5 mm of depression in the joint, now that is actually going to lead to a lot of osteoarthritis later on, especially in the case of young patients. So you need to anatomically reconstruct the knee joint. For that, the most important method is open adduction tunnel fixation, elevation and restoration of joint line. Why it is important? Because the depression has to be elevated. If that is not elevated, actually the ORIF purpose is not served. So now once you have actually elevated the joint line, then you may have to put the graft in, so that the subchondral level graft is placed, so that the joint line does not become depressed once the raft screws are passed. And why the raft screws are nowadays used? Initially it was the cancer screws which was mostly used, but now they usually use the raft screws. Why? Because 3.5 mm of raft screws are biomechanically more stable than 6.5 mm of cancelous screws, and this is the type 2 is actually treated. Multiple raft screws are passed which are biomechanically more stable than the cancelous screws, and actually it restores the joint line. If you see now in this, you cannot appreciate any depression. This was a split and there was a depression over here as well. Actually that has been elevated, graft has been placed over here, and as a result the compression has been achieved at the fracture line. This is very important, that you not only reduce the fracture but you also make it sure that joint line is elevated as well. The other way out of it is how to elevate that joint. If you are unable to actually access the joint because of the femur and the other knee joint structures, then the option is always available called as submeniscal orthotomy. What it is actually using the pulley system to actually pull the meniscus up from the femur level, from the femoral side, and then we can have an access to the tibial condyles. Then that joint line can be elevated, and it's made sure that initially there is no depression as well as there is no elevation of joint line, because if elevation and depression both will eventually lead to incongruency, and incongruency can lead to arthritis. So once that is done, then later on graft can be put on the subchondral level, and later on either use of buttress plates or raft screws, whatever is required, can be utilized to restore the anatomical congruity of the fracture site as well as the joint line. Now if it's tibial plateau type 1 to 3, usually the treatment could be depending upon its how much displacement it is, how much fracture combination it is. It could be simply use of cancelous screws or lag screws. It could be use of buttress plate, or it could be use of elevation by use of raft screws, which is important, because if you see it over here, once that elevation has been done, then this area would be left devoid of bone. So you have to put in graft the subchondral site, so that this depression does not sink back in once you have passed the screws. And once you've done that, then you can apply the screws. You may apply the buttress plate, you may apply even the raft screws as well, depending upon the surgeon's preference and treatment modalities. Different modalities are actually available. So if it's type 4, now as I told you, type 4 means the injury was on the medial side. There may be involved mainly the medial condyle. You can appreciate the medial condyle is highly comminuted, and usually this involves a lot of injury towards the medial collateral ligament as well. And even the excessive treatment, usually they require open adduction and tunnel fixation. in form of buttress plate or proximal tibial anatomical plates. As you can see it on these post-op x-rays involving the Schatzker type 4 fractures. Now coming to type 4, usually if there are osteoporotic crush fractures of the medial plateau, there is always, although this is difficult to reduce, but there's some degree of varus will always remain there later on as well. If you go back and see this slide, they have actually given a röntgengram for this, and you can appreciate the mechanical axis is actually passing right from the center of the hip to the center of the ankle, despite that there was a plating being done. Why we have to see this? Because eventually the type 4 kind of a fracture produces some degree of varus. There is always a chance that despite adequate reduction and internal fixation and joint line congruency, there may be resulting in some degree of varus will always remain, and that is needs to be looked out, because varus, too much varus may be problematic later on for the patient as well, and may require eventually a total knee arthroplasty as well. Now coming to the type 5 and type 6 fractures. Now the treatment for type 5 and type 6, depending upon, usually they involve both condyles. There are high energy mechanisms and usually involving the metaphyseal extension as well. Initially they can be treated with the brace, but usually require open retraction internal fixation. Most commonly the brace can be worn till the swelling settles down, as because it's associated with severe hematoma and a lot of swelling, and if there is no neurological compromise, then we can plan surgery and later on go for open reduction internal fixation as well. Sometimes there is always open fractures may be associated with this kind of a thing, then you cannot put the plates in an open fracture, so we may have to go for external fixation as well. External fixation, this is actually called as ligamentotaxis, because two pins are passed in the femur and then in the tibia as well, and actually that ligamentotaxis is done so that if the fracture is too comminuted and you cannot pass screws through this comminuted fracture, even the buttress place cannot be passed, so that you allow this comminuted fracture segments to settle down and sink in and eventually unite, forming a medial and lateral tibial plateaus. For that you may have to pass an external fixator as well. This is classically, if you can appreciate it over here, that this was a type 6 injury, and you can see a metaphyseal extension right going in along with the medial as well as the lateral tibial condyle. A buttress plate on the lateral side as well as on the medial side has to be placed. Dual buttressing plate was placed along with the long buttress plate on the lateral side, so that this can be metaphyseal diaphyseal junction can be stabilized. This is a lateral view of the same construct. You can appreciate how much screws and metal work needs some time, because these structures are usually highly unstable. Other options you can appreciate. Now this is actually involving the both condyles as well as tibial extension, which can be seen it over here, type 6 fractures. Why the external fixator? This could be an open fracture as well. This could be associated with a lot of soft tissue compromise. So what they have done is they're extending the leg in such a way so that these fragments settle down eventually and unite to form the stable construct. Other options is that we can go for minimal internal fixation in form of screws, as well as along with the utilization of an external fixator as well. Other options most commonly are not overused in everyday life, but usually that is involves a laser off. And the good part is you can do some amount of bone distraction as well as bone transport, along with the correction of deformity, which may eventually present due to malunited medial or lateral tibial condyles. Now coming to the complications. What could be complications of tibial plateau fractures? They may include, the most commonly, if it is more than 5 mm of displacement or more than 5 mm of depression, this may be associated with early complications such as could be neurovascular compromise. Massive swelling can lead to compartment syndrome, or it could be late complications such as joint stiffness. Why? Because eventually if the external fixator was applied, or if the patient was kept immobilized for a long period of time. This will eventually lead to fibrosis and of the joint. Eventually joint stiffness would be present. If there is more than 5 mm of depression or displacement, this may lead to eventually arthritis. If it was not joint congruency was not restored, there may be, especially in the case of type 4, there may be some degree of varus deformity which may develop later on. Now moving on to the tibia and fibula shaft fractures. As you know, it may involve the condyles or they can involve the diaphyses as well. Usually there are both bones may be fractured. It may be closed injury or maybe open injury, or there may be an isolated tibial shaft injuries involving the middle or distal 1/3 of the tibia. Tibial and shaft fibula fractures usually could be different mechanisms of injury. Depending upon the geometry of fractures, a mechanism of injury can be occurred. Obviously, the patient will be telling you the history of how it happened actually as well. If there was a twisting injury, a twisting force was actually occurring on the leg with the foot planted on the ground. This was usually leads to a spiral kind of a fracture, in which there is a spiral fracture in the mid shaft, which may be pathognomic of a twisting force which was actually causing the fracture at the leg. This could be, for example, if the patient's one foot was stuck and the whole body was rotating over it when the force was being applied. This could be leading to a spiral kind of fracture. Other option, the mechanism could be actually once the angulated force occur. For example, the leg was straight, foot was planted on the ground, and the force was actually occurring from one side. This may eventually lead to two types of injury. There could be a transverse fracture, in which the bone breaks off eventually once the load exceeds its tensile strength, or it could be a short oblique fracture, in which there was actually angulated as well as some degree of rotational force which has actually occurred as well. But the one point is, in that case, both the fibula and the tibia fracture at the same level. But when there is a twisting force is occurring, the tibial shaft fracture and fibula fracture may be at different levels as well, depending on at what type of force was actually, whether the counterclockwise or clockwise force was acting on the tibia. Usually the mechanism of injury could be indirect injury or it could be a direct injury. Now, indirect injury includes usually low energy, spiral or long oblique fractures, or bone fragments may pierce the skin from within. As I told you, the most common mechanism is the patient's foot was planted on the ground, was stuck and could not move, but the whole body was actually rotating over the leg. This may lead to spiral kind of fracture. Other mechanism is direct injuries, which may be due to the high energy. There could be crushes, splits of the skin, and most common causes usually the motor vehicle accidents. These motor vehicle accidents actually this results in a direct impact on the knee, could be leading to diaphyseal or diaphyseal tibial and fibula fractures. Now coming to the pathological anatomy, depending upon the behavior of injuries plus the choice of treatment, usually depends on different factors such as is the state of the soft tissue. Why? Because tibia is such a bone in which it's always associated open fracture. This open fracture could mean a puncture wound in which the bone actually came out and went back in, and when you examine the patient there is no bone which is actually exposed to the air. Or it could be this kind of an injury in which you can see it a severely degloving kind of injury. Probably this whole tissue may be necrotic as well, along with associated neurovascular compromise. So the state of soft tissue, whether this degloving, this necrotic, or there is associated neurovascular compromise or not, also determines what type of treatment a tibial shaft fracture needs. Other is severity of bone injury. Severity would mean that there is a spiral fracture, a transverse fracture, or a short oblique, or a butterfly segment, or is it a segmental fracture, or it's highly comminuted. Highly comminuted segmental fracture would mean that this may be associated with very high energy trauma along with a severe soft tissue compromise. Then the stability of the fracture. In case of it's segmental or highly comminuted, the fragments may be highly unstable and may require some form of external fixation as well. And then the degree of contamination. If the patient had an open fracture, where did it occur? Was sweat patient dragged on into the dirt or not? Was there the patient went out of the car and fell in a farm or not? Because these all injuries actually determine how much degree of contamination could have been taken place over the wound area. When the wound was washed, was there any dirt, grass, or other fecal particles which were present or not? Or there were some pebbles which may be actually going into the wound as well. So you need to make it sure that how much degree of contamination is there, what's the stability of the fracture, how much combination is there, severity of the bone injury, whether it's segmental, it's transverse, or it looks like low energy versus high energy a bony injury, and what is the state of the soft tissue, which is important, along with the patient factors. Patient factors means what was the patient is a young individual who has sustained this trauma, or somebody who's maybe 70 or 80 years old, a geriatric patient with multiple comorbidities, severe cardiovascular compromise and low ejection fraction. Then you need to keep all these factors in to decide whether you need to go for conservative measures or you need to go for operative measures of tibial reduction or treatment of the tibial fractures. There is a Schatzker classification as well as Gustillo classification. Usually Schatzker classified for both the open as well as the closed fracture. But for open fracture, Gustillo is more predominantly utilized, and Schatzker is actually mainly utilized for the closed fractures. There are actually 6 types. Then IC1, C stands for closed and O stands for open. But IC1 is there is no skin lesion, although associated underlying there is a bony fracture. No skin laceration, but there is contusion of the skin is IC2. IC3 is circumcised degloving, which may be visible over from the on examination. IC4 is extensive closed degloving, and the tissue underlying may be necrotic as well. And IC5 is actually necrosis from the contusion, which could eventually which could be very much visible. In case the difference between IC4 5 is that there is degloving, then tissue may be necrotic, but it has actually not become blackened out. But once a necrosis from contusion leads to blackness, the tissue, this means it has become IC5 now. Then the most commonly utilized is actually the Castillo and Henderson classification for the open fractures. And as I told you, the tibia is the most commonly bone which suffers from open fracture. There are 3 types. The grade 1, in which this is basically a low energy wound. Wound is less than 1 centimeter with minimal soft tissue damage, and usually bony energy could be a simple low energy fracture such as transverse or a short oblique or a spiral fracture. This is the classical presentation of a type 1 Castillo type 1. Grade 2 or type 2 is actually in which the wound is more than 1 centimeter. There is mild to moderate degree of soft tissue injury and mild to moderate degree of bone injury as well. There may be some degree of combination which may be seen on the fracture site, as well as a large wound, usually more than 1 centimeter but less than 10 centimeter. As you can appreciate, this is a classically grade 2 injury. Now type 3 is actually further subdivided into 3A, B and C. In 3A, these all type 3 is actually include high energy trauma, usually associated with high degree of combination and soft tissue compromise. In 3, the wound may be more than 10 centimeter or maybe less, but this may be associated with soft tissue compromise. But in 3A, at least soft tissue coverage is possible for the bone with that kind of trauma. But in case of 3B, the wound is big enough and the soft tissue compromise is severe enough that usually it requires some degree of flap or a graft to cover the wound, because otherwise the bone will have a periosteal stripping, and bone there may be dead pieces inside there as well, and coverage may not be adequate for the bones, and bone may be exposed to the outside environment. In case of 3C, it is when the vascular injury occurs along with the bony fractures. And this is 3A, 3B, 3C, all 3 are actually high energy trauma. Now coming to the clinical features, what does it include? Usually there will be associated history of trauma. There will be mechanism of trauma with associated bruising and swelling. There may be an open wound, crushing or tenting of the skin, which may be visible if there is closed injury. A patient may or may not be able to move his or her toes. Why? Because if there is associated compartment syndrome or vascular compromise, there may be a lot of problems for the patient to wriggle his or her toes. There may be loss of sensation, although that is something which happens in the, if there is either at the time of injury there is associated neurological compromise, or which the neurological compression which may occur secondary to compartment syndrome. Now some of the x-rays, when we get an x-ray, this is what it could be. It appears to be tenting on the skin, although this most likely has a high energy trauma, closed injury, but you can appreciate this is definitely short oblique with some butterfly segment as well. And if you see this, fibula is fractured at 2 levels. This is also indicative of that this is definitely a high energy injury. This is not a low energy injury. Options, as I told you, then we need to look at the different criteria. What was the status of soft tissue? What was the degree of contamination or presentation? How much combination and stability of fracture is there? And what are the patient fractures which can lead to operation failure? So then once we keep all those factors in mind, we decide whether we need to go for conservative or operative measures. Conservative includes casting, which usually could be Sarmiento cast, or it could be above knee cast as well, which could be utilized as well. And then other options for operative fixation includes, this could be nailing and plating. Nailing means close intramedullary nailing, which can be done, for example, for this kind of a fracture. If you see it over here, there is definitely combination of the middle third and the junction of the distal third and middle third. As we can appreciate, this high energy. Why? Because the fibula is also fractured at a different level. So usually this can be stabilized by, this kind of a fracture can be stabilized by static closed intramedullary nail, which can be done. Other options could be if it's an open injury, for example, if it's a Gustilo type 3A, B, or C injury, especially if it's 3B or 3C injury. Close reduction and interlocking nail and plate can be done till 3A, but usually at 3B or 3C injury you need to go for external fixation. Why? Because the soft tissue condition is so bad that you cannot actually use nail or plates for 3B or 3C injuries. Other option, in case of tibia, the usually much better option is actually using a laser off. Laser off is actually a circular frame, and these circular frames, the important advantage of the circular frame is that the rim is actually surrounding the bone with 360 degrees, and you can go for the reconstruction of the bone, and bone transport can also be done, especially when there is segmental fractures or where there is a lot of bone loss, which may be associated in 3B, 3C injuries as well. With the fixators, they are good for as far as temporary stabilization is required, but bone transport and bone loss cannot be actually recovered, and they may eventually lead to non-unions as well, especially in the case of open fractures. Then other options we can have from these kind of fixators, where these are actually uniplanar fixators. 2 pins are going in the upper segment, and then we have applied a kind of a delta frame in which surgical stabilization can be done. Now if you see, this is classically a 3B injury. The wound is big enough that it will require some form of a flap to cover this much amount of the soft tissue, and the bones you cannot be just left alone. If it's 3B or 3C injury, usually that requires external fixation. They have done it in a plane so that the bone has been stabilized, and then later on, once the bone is good enough for the flap or grafting, then the grafting of flaps can later on be done. And once you have covered the bone, then once the infection has settled down at, let's say, 2 weeks of time, you can go for internal fixation in form of nailing or plating as well. So these are kind of external fixators at temporary measures till the wound is good enough so that it can be grafted, or some form of a flap can be done. And once the bone is actually covered, then we can go for internal fixation in form of nail and plate. Other options which could be there for example is actually plating, but usually not a good option for open fractures. But once the post external fixator, once the wound has actually healed up enough, that we can go for internal fixation in form of plates as well. So what antibiotics, what is it actually the treatment rationale? The first and foremost is always when an open fracture presents you need to go for aggressive debridement. If it's type 1 injury, you need to have at least wash it with 3 liters of normal saline. If it's type 2, at least 6 liters. If it's type 3, at least 9 liters, which actually means at least means you may require more than 9 liters of normal saline to wash. So the important point is to wash the wound with copious quantities of normal saline and then start antibiotics. Usually your first generation cephalosporins are enough. But if it's type 3 injury, you may have to start the aminoglycosides. And if it's a patient had a farm injury as well, the patient was thrown into a farm, or patient had suffered an open trauma where the patient was working in some kind of a farm, then probably you need to start as well the penicillins as well. Along with debridement and antibiotics, you need to go for stabilization. Usually till 3A, some form of internal stabilization in form of nail and plate can be done. But from 3B, 3C injuries, you need to go for external fixator. And then if it's 3B and 3C injury, that will also require a soft tissue coverage in form of grafting or a flap as well. And once the graft or flap has been done, then by that time we can go for some kind of internal fixation in form of nail and plate. And later on, rehabilitation is the most important point, because these fractures usually take at least 3 to 4 months for the patient to be completely rehabilitated and was able to carry out at least some form of ambulation. Now coming to the post-operative management. Post-operative management includes weight bearing, which can be started later on once the fracture starts to heal. Partial weight bearing can be permitted until some callus is seen. If the callus is delayed, we can delay the weight bearing as well. Limb should be elevated usually when the patient is actually at rest. Why? So that the edema does not develop and does not actually complicate the things as well. Early complications include, this could be at the time of injury, such as vascular injury. That could be due to neurovascular compromise, that's massive soft tissue swelling. This could be leading to compartment syndrome, and usually this is associated with the closed injuries, which may require fasciotomy and decompression. And if this is the situation, you can appreciate this is the classical. If there is no vascular compromise, then this is a 3B. Otherwise, this is a 3C kind of an injury. In this kind of a situation, you may have so much tissue loss and so much a problem that they may be associated with severe form of sepsis and infection. So if the patient has developed some form of compartment syndrome, then you need to, this is a medical emergency, and you need to promptly decompress the compartments of the leg. There are actually 4 compartments of the leg. There's anterior compartment, there's lateral compartment, and posteriorly the two compartments divided into 2 compartments, the superficial and deep. Superficially involves mainly the gastrocnemius, lateral and medial head, and then the deep involves mainly the soleus as well. If you see on the lateral view, this is usually the incision for the fasciotomy, because the perforators are more posterior to it. And on the medial side, if you see clearly, actually the tibialis posterior forms the posterior compartment, while extensors such as tibialis anterior form the anterior compartment, and peronei form the lateral compartment. And on the medial side, if you see, actually the incision is slightly posterior to the bone, and on the lateral side it's slightly anterior to the bone, because the perforators are way posterior as compared to the lateral side. This is usually the incision which is given on to release the fascicles and to relieve the patient of the compartment syndrome. Now, what are the late complications? Late complications may include, if the patient was applied a unipolar fixator, this may include malunion. For example, there may be varus or valgus deformity, or this may be delayed union. Delayed union means it may take up to 6 months to 9 months, and despite after having a patient may be ambulating for partial weight bearing, maybe weight bearing for 6 months, but still there is no appearance of callus as well. This must be checked at 9 months as well, and if there is no callus at 9 months, the patient can be labeled as having a non-union, which means no formation of callus whatsoever. This other could be the joint stiffness, which especially in the case of trans knee or trans ankle fixators, there is always associated with joint stiffness, because these fixators may stay there for 2 months, 3 months, or 4 months even by the time patient is fully rehabilitated. And so if the joints remains in one place for 3 or 4 months, this may lead to joint stiffness as well. And osteoporosis, because the patient is not completely weight bearing on the that leg which is involved, and you eventually say the muscle may show some degree of dysautorophy. The bone will show some signs of osteoporosis because of the disuse and decreased weight bearing on that side. And if all things goes well, then may be associated with complex renal pain syndrome as well. Now moving on to isolated tibial fractures. Most commonly, there's always associated both bone fractures, but sometimes what happens is in this kind of fight, or usually in case of low energy fall, especially in the case of children, there may be an isolated tibia fractures only, in which the fibula may be spared, or they may be associated with a green stake fracture, but usually there's a fracture of the diaphysis of the tibia. If you see this X-ray, you can appreciate such X-ray of a child because both faces are open. You can appreciate there is definitely a green stake fracture of the distal fibula with actually a short oblique fracture of the tibia. Probably the force, as you can appreciate, the angulation in this direction, the force was acting like this and eventually producing a fall of a child leading to this kind of a fracture. If it's case of child, usually they can be easily treated in casts, but if it involves the adults, isolated tibial fractures may need close reduction internal fixation with tibial nail. Now coming to the tibial stress fractures. These are very common in the case of athletes, especially those who are in the army recruits, especially those who are undergoing extensive training for their fitness. They usually complain of pain, wage pain in the leg, which may be increased. Usually it's more common after the day's workout or after the exercise. And on X-ray, everything would appear normal. Usually it's kind of a micro trauma which is actually occurring at that level and leading to either one side cortex involving the fracture only. So there is no actually limitation of movements. Range of motion is absolutely normal, and this even MRI would actually tell us that whether this may be associated with fracture or not. If you see, these are the X-rays over here, you can appreciate a thin sclerotic line, maybe over here as well, but not always. If you get an MRI would actually delineate there is a X-ray tibial stress fracture or not. Sometimes even this line is not visible and X-rays appear absolutely normal. So you need to get an MRI to make it sure that you rule out tibial stress fracture as well. Treatment is actually rest along with the bracing, so that over the period of time it heals. And usually the short leg is actually brace is applied and patient is allowed to take rest at once along with NSAIDs and analgesics, so that the patient eventually would heal on its own. Thank you very much for watching sqadia.com.